Hello, my name is David Edis. I'm an orthopaedic and spine surgeon at Victorian Orthopaedic Spine Service. I'm going to talk to you today about sciatica and how it's diagnosed and treated. I'll just share my screen with you so we can look at a presentation I've prepared. So how is sciatica diagnosed and treated? Well, I think the first thing we need to sort out is what is sciatica? It refers to pain radiating along the sciatic nerve to the leg of the foot. In fact, it's not just one condition, it's actually the nerve roots that make up the sciatic nerve, the L4, the L5, and the first three sacral nerve roots that contribute to the sciatic nerve. And typically the pain is coming from one of these nerve roots. And the contemporary term for this condition is actually radiculopathy. It refers to the nerve root that's being irritated or compressed. So radiculopathy is the new sciatica. What causes radiculopathy? Well, most frequently the cause of pain along the sciatic nerve is compression or irritation within the spinal canal for one of the nerve roots, S1, L5, or L4 in that order. For example, we name the condition an S1 radiculopathy if the pain is felt along the skin area supplied by the S1 nerve root, which you can see on this map. So where is the problem? Well, the most common compressive lesion is a disc protrusion at L5, S1, or at L4-5. But occasionally it can be higher up, as in this case. The MRI or CT scan is used to make the diagnosis. And as you can see in this picture, there is an extruded disc fragment coming out between the L2-3 segment and protruding into the canal and slightly towards the tail end of the spine and pressing on the nerve rootlets in the spinal canal. There are other disc bulges in the spine, but because of this patient complaining of pain down the right leg along the L3 dermatome, it was decided this was the likely cause of his pain, and once that was removed surgically, his pain did get better. So what is the treatment of sciatica? Well, it's not always surgery. Sometimes we just try a number of other things, such as painkillers. We can try special painkillers that work on nerves, such as amitriptyline, or some of the anti-epileptic drugs can be useful as well. Physiotherapy can be useful as well to help patients understand positions that are less painful and help with stretching of the nerves while they're recovering. The chiropractors also use manipulation, and this can sometimes be helpful. And some practitioners use acupuncture or dry needling as well to help with this type of acute pain. There has also been use of a TENS type machine which stimulates the skin and can also modulate the pain. Most frequently, however, I use X-ray or radiologically guided injections of steroid into the spine, particularly to the nerve root that's being irritated, to see if that can modulate the pain. If that's not helpful, then this is where surgical treatment can be quite useful. And so we typically wait for around 4 to 6 weeks to see if other means have been useful, and if the symptoms do persist longer, then it's reasonable to consider surgical treatment. And this typically involves removal of the disc fragment along with a small part of the spinal canal that covers it, and this may include a small amount of bone and ligament. This is usually well tolerated and doesn't lead to any longer term problems with the spine. Sometimes we don't have to open the spinal canal because the disc is actually in a very far lateral position, and it can be accessed from outside the canal. In that case, it's just a cut of the skin and a split of the muscles to get to the disc. Most surgeons use some form of magnification for surgery, either a microscope or surgical loops or an endoscope during the surgery. This helps visualise and reduce the incision size, and so we call this a microdiscectomy. my preference is to use a microscope. So this is what a microdiscectomy entails, which is where a small skin incision is made just to gain access to the spinal canal. The nerve sac is gently retracted over where the disc lump is protruding into the canal, and the disc lump is removed along with any other loose disc material within the disc. The intention is not to remove the entire disc, but there is a balance between adequate removal to avoid recurrence and too much removal, which will lead to ongoing symptoms. Most patients typically stay 1 or 2 nights in hospital. The incision only needs to be 3 to 5 centimetres, and recovery is relatively quick with rapid relief of the pain down the leg in most cases. Many patients do experience some symptoms after the surgery, often some numbness or altered feeling in the same area where the nerve had pain, and this can persist on for some days or even weeks. I recommend patients avoid bending and lifting and straining for the first 6 weeks, just to allow adequate healing of the tear that's usually present in the disc.